good afternoon, everyone, and thanks for joining us. My name is Adam, Content Marketing Specialist with Schein, and I'll be your moderator. Today, we are joined by Dr. Stephanie Tran. Today's webinar is being recorded, and everyone will receive the link of the recording in the next week. If you have questions for Dr. Tran at any point during the webinar, please type them into the Q&A, and we will answer them live at the end of the presentation. This webinar is presented by Henry Schein Dental, and no CE credits are being offered for viewing or attending this webinar. With that, I'd like to turn it over to Dr. Tran.
Thank you so much, and thank you also especially to Henry Schein Dental for having me. Today, I'm going to be discussing a topic that I'm quite passionate about and that I'm excited to share with everyone, and that is discussing restoratively-driven endodontics. So my name is Dr. Stephanie Tran, and here's a little bit about me on a video.
Endodontist. That means that I'm a dentist who specializes in treating diseases of pulp. That's the tissue inside the tooth. Most importantly, I treat dental pain and help my patients save their teeth. I've always been a huge science and art nerd. I spent most of my childhood going to museums and reading lots of science books. So dentistry was the perfect match. It's the marriage of science and art. So I wanted to become a dentist since I was 7 years old, and it's definitely my passion. Endodontics involves the science of understanding the inside of the tooth, of understanding microbiology and figuring out the mystery of the diagnosis. It also involves an art to it, the artistry of delicately treating the inside while being minimally invasive. Those are all reasons why I love endodontics and what I do. Unfortunately, root canals get a bad reputation for being uncomfortable, but it doesn't have to be like that. When patients come to see me, I try to make it as great of an experience as possible, comfortable and relaxing, and even kind of fun.
So now everybody knows a little about me and my treatment philosophy. I'm an endodontist here in New York, but I'm originally from California. So I grew up in California. I moved to New York for private practice to practice endodontics, but I grew up in California, went to school there, went to both undergrad and dental school at the University of Pacific, where I did the accelerated program, and that's definitely where my passion for both endo and restorative dentistry started. But I then decided to do a GPR for additional advanced training, continue my studies, and that's also where I gained a lot of the experiences which helped me then decide to go into endo. Some of those things were managing emergencies, managing trauma, odontogenic infections, peds management, those kind of things, which are all additional aspects of endo that are still very important, especially lately in COVID with all the emergency and fractures and trauma management. I definitely saw. So that's definitely where my initial interest that's where I initially first had that interest in endo. So I decided to then practice as a general dentist for a few years, but my love for endo was definite. So I went back to residency at the University of Tennessee in postgraduate endodontics, where I graduated and became a specialist in endodontics so that I could practice here in New York, where I moved back to. And I now do an endodontic concierge private practice and work at several multidisciplinary offices to help manage the patients. So because I work with a fair number of offices that are very restoratively and very cosmetic dental offices, that's definitely where my interest in combining both restorative dentistry and endodontics and how we work together came about. I do talk about that, my passion for endo, different endo education, and that kind of thing on my Instagram, which my handle is Her Holiness the Pulp. And so you can follow me for more education if you like this webinar. But specifically, we're going to be talking about restoratively driven endodontics. And so the things that we'll be discussing are what is restoratively driven endo, access design considerations, since that's one of the most important aspects of it, but also the different aspects of contemporary endo treatment, the kind of technology and advancements that have been involved, and the restorative and endo multidisciplinary treatments and how we collaborate to help us take care of our patients. So one of the tenets of Stephen Covey's very famous book, The 7 Habits of Highly Effective People, is to begin with the end in mind. So what does that mean for endodontics? It's not just about doing a root canal or just about treating the endodontic disease. The end goal of endodontic treatment is to have and be able to maintain this tooth, have it be functional and free from endodontic disease. Part of that is to not only do the endodontic treatment, but the tooth itself has to be restored. So the restoration helps maintain the tooth for the patient's function. So we know in modern restorative dentistry, that's definitely been progressing towards being more conservative. There's advancements in bonding and adhesive dentistry, the advancements in biomimetic dentistry, and the development of many, many kinds of restorative materials that each have different aspects and requirements and the descriptions that each have different functions and different results. It's not just about having just the one type of material like it was back in the day. Now there's so many kinds, but with each kind, there are certain aspects to it that have to be followed. So for contemporary endodontics, it now has to enhance that restorative treatment. So we now have more conservative accesses, conservative treatment itself, and this goes hand in hand with the advent of the new restorative dentistry philosophies. So what are some of these philosophies and what are some of these important rules, basically, or the goals of endodontic treatment to follow? We try to be more conservative with less removal of coronal tooth structure, especially before the access itself, but also the canals shaping itself doesn't require as much tooth structure removal, and so we can avoid removing more coronal, more cervical, and more radicular tooth structure. Additionally, we have improved cleaning and obturation techniques, and the access itself and the obturation itself can enhance the restorative treatment options, which I'll be discussing in a bit. And the different types of endodontic treatment options can also enhance the restorative and aesthetic options. And that means not only how the endodontic treatment, how the root canal treatment is done, but also the adjunctive treatments such as internal bleaching, the way the access is done, or what kind of restorative is done on top of the access. So restorative considerations, the biggest and most important initial aspect is the access itself, because that's going to be the area of the tooth that we as endodontists are going to work together in conjunction with our restorative dentists. So for the access, here in this animation, we can see the pink. The first pink is the traditional endodontic access. Some of the aspects of it are that it's very mesialized, very large. But we realized through more research, and especially through CBCT, micro-CT research, and even through previous research, that the canals themselves are more centralized. So the new accesses, which we can see on the screen there, are going to be much more centered and smaller. And why is that? So discussing the previous accesses, we saw that they were much more mesialized and they were very large. But that wasn't a necessarily mistake or negligence on the part of like how it was developed. It was because of the requirements and what was available at the time. So interestingly, one of the reasons why it was probably so mesialized, like why it was placed more mesial than what the traditional access and what the modern access is now, is that they didn't have advanced visualization techniques. They didn't have advanced magnification, having microscopes, even loops back then when most of these access designs were first done. And additionally, there wasn't an adequate light. So by placing it more mesially, it was probably so that they could even see it. Additionally, we see that it's much larger, and that's because they had recommended a straight line access, removing the internal triangles, which we can see there are the parts of the pulp chamber right above the orifice. And they had recommended a very divergent funnel shape. However, we can see that that removes quite a bit of tooth structure. So we can see in the diagram with the burr, that divergent diagram shows that there's quite a bit of occlusal tooth structure that is removed to make this. And additionally, they were often using like slow speed round burrs to really kind of pull up and remove the roof and the pulp chamber and all that tissue. However, that was probably so that way it would facilitate the kinds of instruments and the kinds of the visualization that they were even able to do. So we know that the instruments that were used were mostly stainless steel files, and the rotary files were often either stainless steel or very initial NiTi, which is like non-heat treated, continuous taper, much thicker and larger NiTi. There's no way to get it in a very, very small access. So these larger accesses would facilitate all those aspects. It would facilitate getting a file in there, would facilitate the irrigation techniques that they had at the time. However, with the advent of technological new technologies in all aspects of endodontics, we can see that that access is no longer needed. We don't need to place it so mesially. We don't need to place it so large. Instead, what we can do is we can do a more conservative access. So we can see in this more close-up diagram that the access itself is much more centralized. That's because we know that the canals, they develop from the middle out. That makes sense. The pulp tissue develops the tooth structure from the inside out. So the pulp tissue itself is going to be centered in the tooth, centered specifically in the CEJ because it's going to develop radially. And because it's centralized, we can then preserve much more coronal tooth structure by then making a different type of access, more of this inverse funnel shape. So we can see here with the traditional, the canals are actually much more centralized than the previous ones. So that's why we can do the more centralized and smaller accesses. Additionally, for the anteriors, we can see that the accesses are placed much more incisally, rather than being really large triangles in the middle of the lingual of the tooth. We can actually do those smaller slots because we've realized that with the advent of the more conservative and newer types of file systems, by placing the access much more incisally, that allows you better access to the lingual portion of the canal system. So additionally, there's different types of contemporary access design. So not only do we have the option to stay much more centered and much smaller, but there's actually several types that we can do in modern endodontic treatment. We can do a restoration leveraged access. That means that, let's say if the tooth specifically already has a class 2, like an MO, we can actually do the treatment from the mesial. And this is very similar to caries leveraged accesses. So we can see here in one of my cases that I actually accessed from the severe mesial. So I accessed from where the caries had started, which was like the mesial pit on the occlusal, and then angled my access towards the canals. What this does is that I'm focusing the tooth structure removal only in the area that absolutely has to be removed. So that in this case, it was from the mesial. But also, I can still make sure I access all the orifices. So we can see in my treatment that and in the intraoral picture, I'm still able to see all the canals, all 4 of the canals, and adequately access them. We can see from the x-ray that I can still get into the distal canals, both the lingual and the buccal canals. And we can, I could adequately clean out the tooth. And most importantly though, even though I could see it with my advanced magnification, I can make sure that I adequately cleaned out the pulp chamber and all the tissue and all the debris so that my restorative dentist is able to adequately access the pulp chamber fully when they restore. So the last type of access are the truss accesses and the ninja accesses. And These are very extreme types of conservative accesses, and they're very, very advanced. They are a little bit different, but still different interesting ways that some people are trying to make different advancements in endodontics. In terms of what I like to use personally for my accesses, my two burrs that I use the most are an 1157 burr. So instead of using really large round burrs, because the problem with those large round burrs or those slow speed round burrs that they used to recommend to like pull up and out is that you can often gouge the walls of the access, or you can remove too much tooth structure because it's kind of like just pulling up without focusing, laser focused on exactly where you want to remove the tooth structure. So the nice thing about the 1157, it's a specifically a round-ended burr so that it won't gouge into the walls, and also that we know that the head itself is going to be about 4 millimeters, the cutting head, so that way I can make sure exactly what my measurements are when I'm accessing. Additionally, what also helps is an endo non-end cutting burr. It's very common to see it listed as like a pulp shaper burr or the endo Z burr. Nonetheless, the importance of it is that instead of being this large round burr, which can then make these round cuts into the walls, by having this nice slim shank, it's usually about a 0.16 diameter. This type of burr, a carbide with a non-end cutting tip specifically, allows you to clean off the wall, to clean out the pulp horns and access everything in the chamber while maintaining that inverse funnel shape. So an access that is smaller at the top and then flaring out to get to all of the pulp horns and everything and adequately clean the chamber. So in terms of the features of this type of access, the newer, more modern types of restorative accesses are specifically either centralized or leveraged in one of the other ways. We utilize improved magnification and improved illumination, both by using a microscope, very, very high magnification loops, and a lot of light. We know that this helps a lot. And additionally, it's that inverse shape. As we can see in the radiograph, it's going to be starting very small. In this case, this access was about 2.5 millimeters in wide. And so that flares out as it gets to where the orifices are so that it still is a straight line. It's not a traditional straight line access or what it used to be where it's just straight line up, because that excessively opens the orifice, excessively opens the access. You can still get to all the canals with that inverse funnel shape because the files are still going to be going in straight. Additionally, it does require, though, the more advanced, newer types of file systems, which I'll explain in a little bit, which help be able to instrument within such a small space. The importance of these accesses, though, is that it still allows for proper visualization, both from the endodontist and from the restorative dentist. And we do this in conjunction with the different types of more modern instruments, including modern files, ultrasonics, special type of burrs, and modern types of both irrigation and obturation. And the most important aspect of this, both in the endodontic and the restorative aspect, is that we're trying to preserve more tooth structure while still adequately visualizing and cleaning out the tooth. We're definitely trying to preserve the pericervical dentin, which is like 4 millimeters total, 2 millimeters above and 2 millimeters below the CEJ. This has been discussed in different pieces of literature. That is an important area to try to maintain more tooth structure to try to prevent coronal fractures. So we can see here, this access was about 2 millimeters wide. And these are just more options for, more examples of different types of accesses that I do. So we can see here, again, it's an inverse funnel shape. In this case, the tooth was severely tilted, so I'm not trying to access it from the straight occlusal, but following that long axis of the tooth, and then still in that inverse funnel shape to visualize and adequately treat all the canals, which in this tooth actually had 5, which was very exciting. And then additionally, not only are we preserving more tooth structure, which is better, of course, for the patient, but we're trying to prevent fracture. We're trying to increase the resistance to coronal fracture. We're trying to increase the resistance to possible root fractures. And these modern types of accesses will still allow us to do the adequate cleaning and shaping for the most part. There have been some concerns of a possible increase of missed anatomy or possible increase in missed canals or possibly leaving debris. So there has been some discussion on the pros and cons of these accesses. But the importance of this access is not just about trying to make it as small as possible. It's also having a very strong understanding of root canal anatomy, of understanding the number of canals are going to be in the tooth in each canal, and where it would be located and how to look for all of them. So having this important background understanding is still going to be super important when trying to design these accesses. So those are rightful concerns. However, if the teeth are treated properly, these concerns can definitely be mitigated. So in this access, I not only kept it smaller, of course, to preserve tooth structure, but this also allowed the initial prep. So this tooth had been initially prepped because it had an older crown that had recurrent caries. So I could maintain the margins and prevent the margins from being involved in the access. So that allows my restorative dentist to more easily be able to restore this tooth with the full coverage restoration that was planned. So all these things that we're doing not only, of course, try to maintain as much tooth structure as possible, but we're also trying to work together with our restorative dentists so that they can do all their treatment well as well. So the last type of contemporary access design are the more extreme types. There's the ninja access, which is like that middle photo on the right. It's a very, very, very tiny access, basically maybe 1 millimeter or 2 round burr kind of size at most. It does require a lot of training to do, and it's very, very advanced. The concerns, though, are that it's very difficult to adequately access all the canals sometimes. So, but it is a more extreme type of conservative access. The other type is called the truss or orifice-directed access. So instead of connecting the orifices through one access and being able to access the entire pulp chamber all at once, it's accessing only the orifices. It's definitely a lot more difficult to remove all the pulp tissue and debris from inside the chamber, and there are some concerns about that. Additionally, there are concerns about being able to adequately restore into it. So that's definitely a current discussion in endodontics about these types of accesses. Just an interesting fun one that I also saw was a truss artificial restoration, which I personally hadn't seen until too often myself, but I saw it in this article. So it's that they, instead of placing a crown, they actually drill holes straight through buccolingually and then place a fiber post in between. I'm not sure how my friends who are biomimetic dentists would feel about this, but it was an interesting thing. However, the paper actually disproved it and said that it actually has poor fracture resistance. So generally, probably it's better not to do it, but it's just an interesting design that people did. But the point of all this is that endodontics is trying to develop new ways of accessing the canals and being able to conserve tooth structure. Whether or not this goes hand in hand with the restorative factors, it remains to be seen, I think. But when doing the accesses, the most important part is trying to work together with my restorative dentist to adequately maintain this tooth for this patient and have them be able to function. So these are a couple of my cases where I did caries-directed accesses. So for example, that in the premolar on the left, the caries was purely from the buccal. So instead of actually accessing from the occlusal, like in a traditional access, I did a caries-directed access. So I removed the caries, there was a caries pulpal exposure, and I was able to then actually access the entire canal system through the buccal completely and be able to do all my treatment. This does hinge on having the more modern endodontic instruments and files and treatment system though. So I actually also not only did the endodontic treatment, but restored it as well. And so what this does is that this gives the patient some options and my restorative dentist some options. Ultimately, I'm not here to advocate whether or not a tooth needs whatever kind of restoration, because as an endodontist, my specialty is to treat the pulp tissue. I work together with my restorative dentist in helping them treatment plan and giving them all the options they need for treatment planning of whatever the restoration is best for that patient. In this case, the patient was able to have a direct restoration through that same buccal access and be able to maintain this tooth without a full coverage restoration for this patient. But it definitely depends on the situation as well. So for the next case on the right side, I was able to access through the mesial. So there was an MO, caries, and restoration. I went through the mesial, and we can see from the intraoral photos that it was angled, so that way I could access all 4 of the canals, still be able to treat everything, and that allows for the tooth to be restored that way and preserve more tooth structure for the restorative dentist to then decide how they were going to design the indirect restoration later on. So some considerations though for how we design the accesses. So it's not just about the caries directed and restoration directed or centralized accesses, but how we decide which ones to do, it does depend on several factors. It depends on considering whatever the future restorative treatment is going to be and what those requirements are going to be. It also does have certain patient considerations. So certain patient factors, such as if a patient is going to be able to open really wide, if there's trismus, if a patient is less tolerant, or adequate visualization and access to all of the canals are going to affect how large and the location of where I decide to place my access. Additionally, that same consideration is going to be whether or not I will be adequately able to clean and do the full endodontic treatment, whether that's going to put too much stress on the files, because the shape of the canal system and the shape of the access itself will affect how the files behave within the canal system. But it also will, the access will affect how my restorative dentist is able to treat this case, right? So it will affect their ability to do the restoration itself. So I need to be able to design an access that adequately cleans and allows them to adequately clean, etch, and bond to restore the case. So conserving the tooth structure is still very important, but we also want to consider all these factors, the biomimetic principles, and adequate visualization and access to the canal system. So regarding contemporary endodontic treatment, the other consideration, of course, after the access itself, is going to be the cleaning and shaping and endodontic treatment of the canal system. So I'm only going to get into endodontic instrumentation very briefly because otherwise it would be just very excessive. I'm very much a nerd on endo instruments, and so I could go on for too long, but I'm going to focus on the important parts. So we know that there are a lot of kinds of files, and there have been so many files that have been developed. So how do we know which one is going to be the correct type for modern endodontic treatment, for restoratively driven endodontic treatment? So first off, the traditional endodontic files. This is a photo and diagram done by my friend Dr. Nate Lawson at Dental Tube. He and I collaborated on some endodontic education discussions on Instagram. So these photos are his, they're beautiful. But he does do a great job photographing and going over certain types of the basic endodontic files. So the barb roaches, the K files, and their cousin, the C files. headstroms, and the rotary files. So for barb broaches, they're generally just used to remove like tissue. But one thing to keep in mind is that they can separate if they are, or the little barbs on the barb broach can actually come off and clog the canal, so you have to treat them with caution. The K files themselves are stainless steel files. C files are carbon steel files, so they're actually a bit stiffer. And the way the K file is made is going to be that it's drilled into the stainless steel blade. So the cross-section design is going to be different than like a NiTi rotary file in general. Headstrom has those like rasping edges, and that's was previously used to do endodontic treatment with like hand files and doing like circumferential filing, that kind of thing. We generally don't recommend that anymore because they can excessively straighten the canal or cause perforations, strip perfs, canal transportation, that kind of thing. So headstroms have to be used very judiciously because they can over-instrument and excessively instrument a canal. But the one important file, especially in endodontics, are going to be the rotary files. Initially developed with stainless steel, then NiTi was developed, of course. Now, the original NiTi files were run at much slower speeds, and they were very much stiffer because they were not heat treated. It was very regular NiTi, and they were continuous tapers. The importance of that is is what part of the reason why the accesses had to be, designed a certain way that you were not going to be able to place this type of stiffer file down a tiny, tiny access. So now, the more modern files are going to be the ones that are heat treated. There are lots of kinds. The very kind of basic ones that we see a lot are going to be like the M-wire, R-wire, fire-wire type of ones. That just means like how the NiTi is heat treated. They're all done differently in their proprietary patented ways. But the importance of this heat treatment is that it allows the nickel titanium to be much more flexible. This increases the resistance to cyclic fatigue, it increases torsional resistance, and because it's a bit like softer physically, it's going to unwind in the canal before separating. I know that some people don't like that, seeing that at first, but trust me, we often would much rather a file unwinds before separating rather than just separating and then not knowing about it, because that way we can visually see it and stop that. Anyway, when heat-treated nickel titanium was developed, they realized that treating it with the heat in a certain way would allow either to maintain the shape memory, so the way we see nickel titanium snapping back to the original shape when we initially bend it, or controlled memory. And that means that when we put a bend into the file, or when we bend the NiTi, it actually does not go back to its original shape. It doesn't straighten. It will maintain that bend. So there are going to be different pros and cons and different ways the files are going to react in the canal. For those heat-treated NiTi files, they also have different types of knout designs in contemporary endodontic instruments. There's going to be not only just continuous taper and continuous designs for the controlled memory files, but there's also ones where the cross-section designs or the different angles will change as it goes down the length of the canal. Additionally, there's like hollow files, reciprocating files, continuous taper, variable designs, where even the cross-section will change within the same file, and all different types. The importance of all this is that each slight design change is actually going to slightly affect the way the file behaves in the canal system. But the important thing to add to the design elements is that a lot of the more modern files are trying to be much more conservative and restoratively driven. So now many of them have much smaller maximum flute diameters. That means that now the diameter of the actual metal file itself is going to be at a maximum of 0.08 millimeters for many of the file systems. The nice thing about that is that you can then still have a certain tip and taper size in like the apical section, but it will rapidly change in both the size and the taper of the file and gets much slimmer faster. And what that does, a couple things. Number one, that allows the canal to still be adequately instrumented to a certain size, ending size that we want for adequate irrigation. But it also allows for less tooth structure to be removed because the file is not as wide and is not as tapered. So those are both aspects that allow us to conserve more tooth structure and be more conservative for the overall shaping of the tooth while still allowing for adequate cleaning. In regards to the reciprocating files, there's a number of types, but some of the most common are going to be, of course, Wave 1 and Wave 1 Gold by Dentsply. There's self-adjusting files. That one's not too common in the US. It's actually mostly an international file. It just never really got sold as much in the US for some reason. But then also, similarly, they're going to be these hollow files. So these files are often purposefully curved when they're developed, so that when they rotate inside the canal, it has like an envelope of motion that's supposed to allow irrigation solutions to go in and out of this area, as well as it allows the tooth to be less instrumented, so more tooth structure to be conserved and used in different aspects. So for example, the True Shape and XP, the Brasseler XP finishers and XP instrumentation files are really interesting for retreatments as well, or as irrigation adjunctive files. So as we can see, modern endodontic files are no longer that normal stiff NiTi. We've now developed many types to do many different things within the tooth, and each file design is going to be used in different ways to help enhance conserving tooth structure and adequately cleaning the tooth. Other technology that has developed, of course, first, one of the most important has been the surgical operating microscope, but in conjunction with the microscope, it's having much more increased lighting, such as LED lighting, to adequately visualize everything inside the tooth. And we know that that's been extremely important for restorative treatment as well. But just as important has been an improved understanding of dental and canal anatomy. And that has been enhanced by not only digital radiography, of course, but also through the advent of CBCT and micro-CT. So just to touch on micro-CT and CBCT, the two of those allow us to 3D visualize the tooth, but the micro-CT, which has a much smaller voxel size and like a much higher resolution, is only able to be done on extracted teeth. So it's not for patient or clinical use itself, but it's for us to visualize the teeth when we are doing various research. The CBCT, as we know, has been extremely important in dentistry, both for general treatment planning on a larger scale, like for implants and surgery, but also extremely important for endodontists, because this is how we can visualize the tooth, we can visualize resorption, sometimes we can visualize fractures, but most importantly, it allows us to visualize both the canal system, whether an existing root canal is within the canal system, and the shape of the bone loss and how that affects the tooth as a whole. So it helps us with our treatment planning greatly. So in regards to the CBCT itself, we're able to use it not only to just see the canals, but because the CBCT has been shown to actually have extremely accurate measurements, we can actually measure where the canal should be and where it is in relation to the other canals. So we can see in the above photos that the tooth on the right, the molar on the right, that's actually a lower molar. The canals actually split very quickly, and then but we can map out where the canals should be in relation to each other, like exactly how many millimeters buccal or lingual or mesial or distal. So we can use that when we're trying to find canals. So one thing we can do is you can take mid-treatment CBCTs and see which canals have been found and map out the other canals. Additionally, you can take them pre-operatively to be able to know exactly what the canals look like, how many there should be, that kind of thing. And then also it's important for us when we're treatment planning like surgeries, looking at the amount of bone loss, deciding like prognoses and treatment planning in conjunction with our other specialist colleagues and restorative dentists. The other important aspect of the technology is that we wouldn't be able to just treat teeth so minimally and do minimal instrumentation if we're not able to adequately clean the canal system. So there have been advancements in not only the file designs, but the irrigation and cleaning techniques. So for example, there's sonic, ultrasonic activated irrigation, multi-sonic activation, which is using like sound wave kind of system, as well as laser activated irrigation and PIPs. So the bottom diagram shows some of the different kinds of the laser activated ones specifically. So with all these different types of irrigating activations, the important aspect of it is that you're energizing the irrigating solution, activating it more to improve the efficacy of cleaning not only just within the canal system, but being able to clean the entire canal system in a 3D way. Additionally, the obturation itself has changed. So by instrumenting and by accessing smaller, we have to be able to still obturate these smaller shapes and still preserve the tooth structure, but adequately seal the root canal system. So we've seen that in a number of different advancements. Not only have we advanced the way the gutta-percha is designed, the shapes, laser matching the file shapes with the gutta-percha and the paper points, but also the types of obturation options that are available. So there's like different warm techniques such as the continuous wave condensation or warm vertical obturation, thermoplastic and plastic and gutta-percha based carriers, as well as, most importantly, one of the most recent techniques is using a single cone or a type of continuous wave condensation, but using very high flow resin and bioceramic sealers. With these types of sealers especially, they are able to flow more, obturate the canals and the tubules within the canal system much better, and get into all of the different aspects of the canal system because we want to adequately seal it after properly cleaning it. So we can see in the radiographs, this was a case actually recently where I could tell from the shape of the periapical radiolucencies how it's like 3 lobes, that there would probably be 3 like areas where the canal system went, and sure enough, I was able to adequately clean it in a minimal way. So I actually did a caries leveraged access into it. And the obturation showed lateral puffs in all those areas. So those 3 lateral puffs, actually almost a 4th one on one of the canals. That tells me I was able to adequately seal the canal system. Now, after accessing and obturating, there also is the restorative management itself. And there's some things that as the endodontist we can do to help drive that restorative option for the restorative dentist and for the patient. So the things to keep in mind for restoratively driven endo is that we want to still keep it in line with biomimetic and adhesive and conservative restorative dentistry principles, and allowing for more options for the restorative dentist. And the biggest way is by conserving tooth structure and making sure we can adequately enhance the options for the restorative dentist. And part of that is just by managing the patients well and giving better patient service. So this, for example, the bottom case I had, this case was a patient that had a crown that has an existing post and an existing root canal that's clearly completely reinfected with a recurrent caries. The concern, though, is that the restorative dentist wouldn't be able to place a crown or place some sort of restoration on this tooth before I do the endodontic treatment, because there's nothing for the crown to hold on to. There was like not really they'd have to like try to prep the ferrule, but then how do you get the crown to stay on? You can't cement it. That would prevent it from being able to be accessed. You can't place a post because then I wouldn't be able to do the endodontic treatment. And we can't just leave the crown off because what patient wants to walk around without a crown? So there are certain things like that we can do as endodontists to help be involved in more multidisciplinary comprehensive treatment. So for this patient, what I did was I took an impression of it just in case the crown came off. Of course it did when I did my endodontic retreatment. But after the endodontic retreatment, I knew I wouldn't, since the post was stuck within the crown, I wouldn't be able to just put the crown back on and the whole thing's contaminated with caries and bacteria. So I actually restored the tooth the same day, so that way the patient has a tooth and the tooth is basically ready with a post-core buildup for the restorative dentist to then do their restoration. And on top of that, they now have the impression that I took, as well as they can take an impression of this or a scan of this area to make a temp for the patient. Additionally, there's other things that we can do. So in this case, it is a case where this patient has a very, very large bridge. Of course, there's just no way we're taking this bridge off for this patient. So what are some things I can do as restoratively driven endo to help enhance the treatment for the patient and make sure we help the restorative dentist and work together with them? So what I did was I accessed through the bridge because the bridge itself was fine. But we have to keep in mind here, the bridge was not just normally like designed. We can see there's actually like a tooth in between two adjacent teeth. So everything is set slightly like off-centered from the crown itself. So that's why we can see my access is actually much more distal on that tooth. I had to do that because the tooth itself was more distal than the crown, the occlusal crown. So the importance of that is that I'm, respecting the restorative treatment that's there, but adjusting my access and my treatment to better enhance that and, not perforate anything, make sure I stay within the center of the tooth. Since this bridge was also being maintained, I could then restore directly through that access for my restorative dentist. And we can see kind of the big differences between like an old style access, which was very large. That was the existing root canal. It's very large, it's much lower on the tooth, much more cervical, and mine is placed much more incisally, as well as being much smaller and then slightly off-centered because it's where it's centered on the tooth. Additionally, by having more options for the restorative dentist, they're able to then decide what kind of design and what kind of restorative treatment is the best option for the patient. I'm not here to dictate what kind of restorative treatment is going to be done on top of the endo. I'm here to, as an endodontist, to help enhance the restorative treatment. So by conserving more tooth structure, by even doing the restorative, the access closure sometimes, this allows the restorative dentist to then be able to decide what's the right fit for the patient. What kind of indirect material, is it going to be a direct or indirect restoration, or even the type of indirect restoration it would be, an inlay, an onlay, a full coverage, what kind of cuspal coverage, the new kinds of like crown lay, biomimetic, like flat pancake, all different ones. The restorative dentist is going to be looking at the patient as a whole, looking at their occlusion, the kind of restorative options and the kind of restorative materials that are going to be the best fit for this patient. And where they can place the margin. No longer are we just doing like full coverage crowns with the margins to the gingiva, but we know that we can place them in different areas or even use CAD/CAM technology to help design the crown in the best way for the patient. So by restoratively driven endodontics, it helps enhance all these options for the restorative dentist. Additionally, we want to be able to offer patients a really good service. So for example, in this case, so I'm just kind of going through these different cases to show the different ways restoratively driven endodontics helped enhance restorative treatment. In this case, the patient had fractured all three teeth very close to the gingiva, and of course, they're right at the anterior. So by I was able to not only schedule the treatment, but also manage my accesses and my canal shaping in such a way that now the patient was immediately ready for the restorative dentist to then restore the teeth the same day, thanks to modern restorative technology. So these two things go hand in hand to create not only beautiful restorations, but adequately care for the patient and provide a great service for them. Lastly, one thing I'd like to talk about is an adjunctive treatment, which is internal bleaching. So we can see from these images that, which was taken by my colleague, Dr. Tommy Yee, internal bleaching is able to help enhance the treatment in several ways. Now, we're bleaching the tooth, but it helps with the different restorative options as well. So first off, not only can it be an option to just be able to whiten the tooth, match the other teeth adjacent, and that just can be the last of the treatment, and the tooth can just be restored directly through the access. But we can also do internal bleaching to help with possible indirect restorations as well. Namely through, number one, by changing the stump shade, because we know that for many of the more cosmetic restoration types like the porcelains and the different ceramic restorations, by having that translucency, a very dark stump, a very dark prep is going to be much more difficult to color match adjacent teeth. And yeah, we can place opacers and things like that, but sometimes that can be tough. So by changing the stump shade, we can help enhance the restorative aspect. The lab is going to be able to make a better color match, that kind of thing. But not only can we enhance the stump shade after a tooth's prepped, but even before prepping an indirect restoration. So let's say, for example, for a veneer or certain types of ceramic anterior restorations, we know that that the restorative dentist would have to cut back a certain amount in order to have a better color match. But now we're going to be able to conserve more tooth structure, because if the tooth is already starting off at a lighter shade, the restorative dentist might not always have to reduce quite as much to make that restoration be a good color match. So those are some great options as an adjunctive endodontic treatment that we can do for a patient, and that helps for the restorative treatment as well. It's just some things to keep in mind though, that there can be like certain risks, and sometimes the color does not change as much as we'd like, but it's still a great option for a lot of cases to help with the aesthetic results. So we can see here, this is an internal bleaching case that I did where I was able to do a minimally invasive access through the lingual. We can see that the tooth was a little bit gray, and then the result is quite nice. A lot of times we may even aim just like slightly lighter in shade than the other teeth, because there will be often some reverting of the color, which a patient has to be aware of. And for the materials, we usually use either carbamide peroxide or straight hydrogen peroxide gel. And we've seen through the research, it does not always require a really large access to be able to do internal bleaching. We can actually still do our minimally invasive accesses and still be able to adequately change the color and do a better shade match, such as I was able to do for this patient. And additionally, as my last case, this was definitely a really fun, interesting one, because the anatomy was so unique. We can see there's multiple aspects of the restorative treatment that I took into consideration in addition to the endodontic treatment as well. So we can see the different principles that came into play here. The access itself on number 19 was able to be very, very small with that inverse funnel shape, but still able to access all 5 of the canals. Whereas for the tooth number 18, the second molar, that actually had 3 canals. With the modern treatment, I was able to remove the entire core buildup and able to access the entire canal system, adequately treat it, and still be able to remove an old root canal without excessively opening up the root canal system or excessively over-instrument the canal system. So the importance of all these aspects is by maintaining more tooth structure, we now have more restorative options and more tooth structure to helpfully conserve and have better structural integrity for the tooth. Lastly, in this case, this was a really great case that showcases the multidisciplinary management of a lot of these cases. So in this treatment, the important aspect of it is actually on a fellow dentist, a colleague of mine. And I worked together with my friend, Dr. Devin McClintock. She was the restorative dentist. She's actually an AACD member and an AACD resident. So she's well-versed in advanced restorative techniques. So it was great working together with her and seeing what we were able to do in terms of tooth structure management, patient management, and restorative options. So for this patient, unfortunately, they had large interproximal caries, both of the first and second molar. We can see in the photo, the radiograph, I had done the root canal treatment on the second molar already just recently before the restorative treatment. And then the patient was able to then coordinate appointments both with me and the restorative dentist, Dr. McClintock, at the same time. So to manage the timing, Dr. McClintock actually saw the patient first after I did my first initial endodontic treatment. She prepped the teeth. Because we're able to be so conservative, she actually did onlays, and that was able to conserve a lot of tooth structure for this patient. Then she did the permanent restoration, the core buildup of tooth number 15. But what about tooth number 14? She's prepped it, and now I have to do the endodontic treatment. So with restoratively-driven endodontics, with adhering to these conservative principles, I was able to design my access from the distal into the tooth and actually access all the canals, all 4 of the canals on both teeth, specifically through the caries area, and not affect the margins, and make sure that I didn't affect the overall prep, because she had already scanned it for a CEREC, for 2 CEREC onlays on this tooth immediately after. So right after my endodontic treatment, we were able to then restore the teeth right away, which is a great service and able to maintain a lot of tooth structure in order to do it. So we can see here, when I did my endodontic treatment, I angled it, and then she was able to cement the crowns immediately after. So we could see the before and after, thanks to the photos that she took. So overall, we've discussed about restoratively driven endo, we've discussed the access, the treatment itself, and the advancements in technology, but the main thing we want to take away is that this allows us, for both in endodontics and restorative dentistry, to work together to comprehensively take care of the patient and maintain this tooth, hopefully for a long time, by maintaining more tooth structure and adequately treating the tooth and function on it. So thank you so much for everyone for tuning in to this webinar. This is my dog, Mango, and you can see more of him, more about me, and more endodontic education on my Instagram at Her Holiness the Pulp. If you have any questions that you want to reach me directly, you can definitely email me, and my email is there. And thank you so much to everyone for tuning in, as well as thank you again to Henry Schein Dental for having me on to talk about something that I really enjoy, so that way we can all work together to maintain more tooth structure for patients. Thank you so much.
Great. Thank you, Dr. Tran. We've got time for a couple questions. First one is, when you obturate, are you using master cones and accessory cones, heated obturators, or are you using something else?
I'm generally using master cones and not the heated obturators, but like the down pack heat tips, like those that, and so instead of using like the old school Bunsen burner, the heat tips, either you can use cordless or corded ones, but that's transferring heat into the gutta percha. In general, you're using a master cone, so we're talking about the more modern techniques of the laser measured gutta percha cones that match the files, so that way they will be a very close fit. However, we know that the canals are not always just perfect circles. There's going to be 3-dimensional aspects to it. And that's why it's important to add both accessory cones for certain canal systems, like oval-shaped canal systems. Even when you put 2 cones in there, there still might be space. So adding in accessory cones to help then heat everything down to spread the gutta percha is going to be important. So that's how we manage the obturation.
On the first contemporary access design, picture that you shared with us, is there file separation in distal lingual canal? If there is file separation, do you think it's from an adequate access opening?
So there wasn't, if I remember correctly, which case, I mean, I'm not, that didn't have a file canal. That's probably either from the, that happens a lot where the overlap of the gutta percha makes it more radiopaque. It makes it look like a file or something like that. But there wasn't any file separation. However, that's a good question. You can have file separation if there's excessive force or excessive stress on the file. That can be caused if an access is not adequately managed, which is why it's going to be important to adequately manage the access and open it up as necessary to allow the file to work inside the canal without excessively stressing it. So that's why that understanding of like the file designs, the metallurgy, and how the access will allow the file to go in there is important.
How do you clean the pulp chamber on the most minimal accesses?
So that's a great question. There's a few ways to do it. The nice thing about that inverse funnel kind of design, or even from the caries directed, caries leverage or restoration leverage accesses, is that I'm actually purposefully angling it to so that the pulp chamber is still fully visible, and we're able to clean it out fully and actually access into the pulp horns as well. A lot of times you can use, like if there's really stubborn tissue, you can use a small spoon, very, very tiny endodontic spoons, the long ones, to excavate it, as well as very small, like you can use an Endo Explorer, you can use a file sometimes to pluck it out, and even just an ultrasonic tip, we often will use that to adequately clean it if there's still a little bit of debris stuck underneath, like a pulp horn or something like that. That and adequately activating and having a lot of irrigating solution will help flush a lot of this out as well.
Great. And then our last question, what is your preference of using a metal post or a different type of post? And if a different type of post, what?
So, I mean, as an endodontist and also in restorative dentistry, we've seen that we don't always need posts anymore. The advancements in adhesive dentistry and bonding and the type of materials that are available allow for the grand majority of restorative treatment to not always require a post. But let's say you absolutely need a post for a certain case. In general, the concerns about metal posts, with the exception of certain like cast posts, but like with prefabricated metal posts, is that because the metal is a different modulus of elasticity from the tooth structure itself, there's going to be concerns of causing that difference of modulus of elasticity to cause like fractures in the tooth. So fiber posts in general are going to be related to fewer root fractures than a metal post. However, it does depend on how the post is placed. So if you place too large of a post, doesn't matter whether it's fiber or metal, you're going to put the tooth at risk. But additionally, if the metal post is like really twisted and tightened into the tooth and there's excessive force, then that's going to put it at risk as well. So in general, the rule of thumb would be like trying to avoid posts as much as possible. With bonding dentistry, we very rarely have to put posts in as much as we used to. And then if you absolutely have to use a post, a fiber post or some sort of bonded post is going to be better.
All right, well, that'll do it for us tonight. For those of you who would like to get in touch with Dr. Tran, feel free to email her directly or go give her a follow on Instagram. Otherwise, if you have additional questions, please email us at webinars@henryschein.com and we will answer them for you. Everyone in attendance tonight will receive a link to view the recording in the coming week via email. On behalf of Henry Schein, thank you all for attending and have a great evening.
Great. Thank you so much, everyone. Again, have a good night.